Hello, sir.
Hi.
So today we are going to discuss about adrenal insufficiency, and on this regard, I wanted to ask you, what do you think? How common is it in India?
Adrenal diseases have been always underrated in this country. Fundamentally because from endocrine point of view, we are inundated with diabetes and thyroid disorders. And most of the attention is being given to these two endocrine disorders.
Okay.
But I must tell you, doctor, that endocrine disorders of the adrenal gland are not that uncommon in our country. We are a huge population, and where birth rate is very high. Congenital adrenal hyperplasia is something that happens at birth. And if it is really very serious, leads to adrenal crisis, right, in neonatal life.
Yes,
And very rarely gets diagnosed unless you are in a major town or give birth in a major hospital. Or later on comes up as with precocious puberty or ambiguous genitalia. That again only would draw the attention of the people if this patient's family managed to bring this kid to a tertiary care center. But from my perspective, I would say the commonest cause of adrenal disease in our country is misuse of steroids. So many times people give steroids for varied reasons, and a lot of people give it for rheumatological diseases. Very few people give it who are genuinely trained to do so, but a lot of people do it for the heck of it because it seems to temporarily make people feel well. Right from simple osteoarthritis to rheumatoid arthritis, whether it is indicated or not. People use it for a lot of chronic respiratory diseases, right from bronchial asthma to acute respiratory infections. Pollution becoming so common in the subcontinent. All cities are choked up with smog and smoke. So this is becoming a major issue, not responding to routine conventional therapy, people sucking in steroids. Dermatological issues, chronic eczemas, pemphigus, whatever. Give a steroid for a fortnight, a month, people feel pretty good. But all these things at the end of the day end up in suppressing your hypothalamo-pituitary adrenal axis. And literally any form of therapy that you give beyond 2 weeks will lead to some form of adrenal insufficiency. Either it will be overt Addisonian disease, or it might be insufficiency which will become manifest during a stressful situation. Let's say somebody develops infection and his adrenals are not able to cope up to generate as much of steroids as he would need. So he collapses, develops a hypotension, septicemia, and dies down unless treated and diagnosed. Or somebody has a trauma, a minor trauma, a moderate trauma. His steroid levels normally goes up to do vasoconstriction, to hemostasis. It doesn't happen because now his adrenals are partially or sufficiently knocked down. So he has a problem. Or somebody who is otherwise okay, comes with a blood pressure of 110/70, you put him to surgery. Surgery gets a bit prolonged and goes haywire. The fellow doesn't come out. His blood pressure doesn't come out. You keep on giving him a support in terms of vasopressors, but underlying this hydrocortisone or cortisol deficiency does not come to our mind. And this form of adrenal disease is the commonest issue. We have published myriads of papers on this and tried to educate people all across. But unfortunately, steroids in particularly rheumatic diseases or skin disease are not only practiced by the trained allopathic physicians. All sorts of people with alternative background of medicine do practice them in different shapes and colors, either as powders or as tablets or as injections or a quick relief phenomena. And it is that class of people where you will find it very difficult to diagnose what has gone wrong. So I would say from Indian perspective, as you asked it, this will be a major problem. Then second issue is that infections can involve adrenal gland. And whatever the magnitude of non-communicable diseases, infections continue to be a major group of disorders in Southeast Asia. They still kill most of the people.
Definitely.
Tuberculosis, very well known. We know of many studies that came in from different centers showing calcification of the adrenal gland through different imaging tools and showing decreased production of cortisol from adrenal gland. Either this ending up in such calcification and fibrosis of both the adrenal glands that it leads to overt Addison's disease, which you and me diagnose,
Yes.
or the same insufficient state which comes to the fore during a stressful situation when in a routine Indian setting it will be very difficult to conceive as a hypocortisol state. So that tuberculosis continues to be a major hassle. It has been a major hassle. We have published a lot of data on this where we have shown that people with tuberculosis of any part of the body, one group having overt Addisonian disease, you need adrenal support. Second, if you look at after cortisol ACTase stimulation, the area under the curve for patients who have had tuberculosis, in 1/3 of people, the total secreted cortisol would be much lower than a control population in a stressful situation, even when in a stimulatory situation. That again would put this population at a disadvantage. And last but not the least is a big class of women whom we have characterized as seen. We have probably seen more cases of Sheehan syndrome than Sheehan has seen himself.
Yes, sir. Probably.
We have documented more cases of Sheehan syndrome than Sheehan did himself. And when I am talking about this disorder in women in Jammu and Kashmir, I have no reason to believe similar would not be the situation in Bihar.
Absolutely.
I have no reason to believe situation would be better in UP. I have no reason to believe it will not be same in Jharkhand, Chhattisgarh, Odisha, West Bengal.
Well, even in Mumbai we see.
No, and I'm just telling you. That's what is the predominance
Yes.
of continent. And we have seen so many women who have survived an episode of bleeding, because many can die and many do die,
Yes, sir.
who survive an acute event coming months, years later with some form of a pituitary deficiency. If they acutely come to us, that will be a shock, hypertension. Or if that is not a major issue, then first presentation would be lack of lactation, because prolactin hormone is gone. But in a chronic state, the most things that happen is hypothyroid state and hypocortisol state.
Right. The central
And many times the same individual would succumb to a routine infection because of a hypocortisol state. The same individual succumb to a routine minor trauma because that has not been diagnosed in time. So these will be some of the issues that are very peculiar to subcontinent. And if you actually understand the quantum of them, then I am sure we will not be these issues will not be far behind the diabetes and thyroid diseases. It looks lesser just because we don't have the proper tools to diagnose them in time.
I agree. In fact, I've diagnosed a few who presented with hyponatremia and turned out to be Sheehan's.
Absolutely. Absolutely.
And the other infection probably histoplasmosis
Absolutely.
Where-
Absolutely.
down the line.
Why I was in particular referring to tuberculosis because it is so universal.
Common, most common.
Universal
Most
still in our own country.
Most common.
In fact, still in the whole Southeast Asia, still very common.
So in such a context, how would you diagnose adrenal insufficiency?
I'm saying, in all these things, you need to have a very high index of suspicion. Is if somebody has had a tuberculosis, if somebody has had any of those rheumatological disorders, cutaneous disorders, chest problems, has been going to alternative medicine, has been taking steroids. Somebody who has been having, had a menstrual cycle did not occur regularly after last pregnancy. She could not lactate properly. In any one of those individuals who has problems with electrolytes, who has problems with blood pressure, we need to suspect it. And I must tell you, amazing thing that, I was just now telling you about Shayana syndrome. Many
Yes, sir.
patients, many of our own residents who from endocrinology walked into hematology found out that many patients have myelodysplastic syndrome, had amenorrhea from their last pregnancy. So the Department of Hematology at our own institution was treating them for myelodysplasia. Were sent to us, and in many patients we diagnosed Shayana syndrome, and we were amazed. Myelodysplastic syndrome vanished. We published a paper more than a decade back in Annals of Hematology. Then we did a case control study and published it in Pituitary 7-8 years back. So there are so many facets of this that still elude the comprehension. So we need to keep an eye open. Diabetes epidemic became known only because we could make a blood sugar estimation everywhere in the country. So unless we can estimate this, see, look at the cortisol dynamics on this huge epidemic which I strongly believe exists, obviously not to the tune of diabetes but which compromises the mortality figures, morbidity figures of very routine sickness, as I was telling you about surgery, trauma, routine infection. Unless we have that diagnostic wherewithal available through thick and thin, like glucometers, I think still lots and lots of people are destined to suffer. But at least we should become aware of it.
Definitely. So when you look at cortisol dynamics, nowadays we have cortisol levels available, and many people routinely order early morning cortisol and afternoon cortisol and then midnight. All three are essential?
I must tell you, fundamentally a random cortisol will tell you nothing.
Yeah.
It will tell you nothing. When you look at a patient, the fundamental point is what are you suspecting? Either a hypercortisol state or a hypocortisol state. So if you are expecting a hypercortisol state, you do a test by which you suppress cortisol.
Yes.
And if your cortisol gets suppressed, your diagnosis of hypercortisol state is nullified. And if you expect a hypocortisol state, you have to do a secretory test or a stimulation test. There are varied ECT stimulation tests. And a random test will not tell you much, but this will tell you a lot. But if you say sometimes if you are looking at, let's say, hypercortisol state, some form of a Cushing's, you do morning, evening cortisol and you find out it's pretty high, both are pretty high, circadian rhythm is gone, it makes you suspicious. Then you still do a suppression test.
True.
Right?
Yes.
And you do a random test and you find very low cortisol, it increases your suspicion. But confirmation still come from an ECT stimulation test, because managing this is going to be a hassle, so we need a confirmatory test before we actually get into the nitty-gritty of managing it, which has its own hassles.
Yeah. So, I mean, since obviously once we've diagnosed someone to have adrenal insufficiency, we move on to the therapy part of it. And which is the form of glucocorticoid that you would prefer or advocate while treating adrenal insufficiency?
In most of the instances, we would prefer a relatively shorter acting drug. So hydrocortisone would be a preferred drug. But many times, convenience, say prednisolone is being prescribed, but much longer acting drugs, usually in a chronic state, we do not advocate. And those are the drugs which are for emergencies. But otherwise also, in routine things, we hydrocortisone. And if there is a mineralocorticoid deficiency as well, then we need to go flow hydrocortisone to take care of that. But then once you come to the nitty-gritty of that, then by then it needs to be in a relatively more professional setup, who can zero in on the, because it's a bi-edged weapon. You underdo the treatment, you continue to have a hypercortisol state. You overdo the treatment, you have a subclinical hypercortisol state. So you need to be a very refined professional to do that clean dosaging of an individual and looking at the benefits of under-treating or over-treating.
So clinical as well as biochemical parameters to look at.
Absolutely.
How do you titrate the doses?
Absolutely.
there's a school of thought which talks about, whatever we've been doing in terms of replacement so far, we probably were overdoing it, and probably now the newer concepts talk about, relatively less glucocorticoid requirements for an individual. So your thoughts on that?
I'll tell you, I have been amazed for decades. I was telling you just about Shihans,
Yes, sir.
we've been treating hordes of them from 80s. And naturally, once you confirm in a tertiary care settings that somebody's hypothalamo-pituitary adrenal axis is knocked out, minimum, because they happen to be adults who are giving birth to
Yes,
children, we would give a minimum of 7.5 milligrams of prednisolone, 5 in the morning and 2. And I was really amazed. So are my younger colleagues who are running the department now, that even at this, these ladies would develop Cushingoid fascias. And many of those patients are well controlled eucortisol at 5 milligrams only. So we thought, actually telling you honestly, that is it possible that Sheehan's component, there was a small component of autoimmune disease which was sort of recovering, and so I totally agree with this thing. That's why I'm telling you, this fine tuning is extremely important. I have seen many women in my own practice in the last more than 3 decades who developed Cushingoid fascias, a bit of an hypertension at 7.5 milligrams of prednisolone, and we de-escalated it to 5 milligrams. Things seem to be settling down, but we need to understand its biology before it could be advocated to public at large or medical profession at large. But this is my own observation for decades.
So on a few occasions, I've noted that people on glucocorticoid replacement during fine titration, there have been a couple of people or individuals talking about monitoring cortisol levels. How do you do that?
Very difficult, by and large, best titration would be clinical, as I told you. What happens to electrolytes, what happens to blood pressure, what happens to symptoms, how a person responds to stressful situations. But one thing is extremely important that we need to understand. All these people, whatever dosage we end up in giving, they need to be given a lesson on sick day management. If they get a concurrent sickness, if they get operated, if they have a surgery, if they have a trauma, they should have a card. They should educate the doctor, because then their cortisol dynamics would dramatically change and the doctor would need to take care of that, because that will be a period when they will, in spite of that adequate replacement therapy, would still be predisposed to Addisonian crisis. So that is one thing that also needs to be understood, that a sick day management needs to be told to these people, and the doctor who treats them during an acute sickness needs to understand that.
So I think to add to that, probably even the bone physiology part of it in terms of bone health on glucocorticoids. Anything, your comments?
Again, I'll tell you, osteoporosis is going to be a huge issue in this part of the world and in our own country. We have been talking for a long time now, young India and so many young people, and young does not take long to become old geriatric population. Over a period of time, we will have a huge elderly population, geriatric population, and postmenopausal women. All those guys who have been, either exposed to steroids or exposed to these disorders that we alluded to, or have some subtle features of a postpartum pituitary dysfunction which was not diagnosed. And then on top of that, you give steroids. That osteoporosis, that is age-related, that is nutrition-related first. Osteomalacia rickets walking into this thing, which still continues to be a major hassle. Every segment of our society, every study still continues to show how at mass level we continue to be vitamin D deficient. And on top of that, osteomalacia rickets, you develop osteoporosis, you have postmenopausal osteoporosis, you have senile osteoporosis, then you have steroid intake. Sune pe sohaga. It will break the bones of the nation. Choice is ours.
So I think the most important point that I gather from this talk is that the index of suspicion should be very, very high.
Absolutely.
That's number one. Number two, as you said, it can affect at all ages. Absolutely. And only you need to be more and more vigilant to pick up these cases.
Absolutely.
And second thing on therapy, I mean, probably we need to do a clinical assessment and the lab related assessment to decide what is the optimum dose.
Absolutely. And the right people need to do it. Not the roadside people.
And the most important thing, I mean, the crux of it is the sick day schedule, probably that these individuals need to be
Absolutely.
emphasized on.
And we as medical professionals need to be aware of it.
Yeah.
Because why I'm saying it in particular, these guys live you see, in chronic treatment, they may go to the best centers in the country. But when they get an acute sickness, they go to the doctor next door. This fellow gets pneumonia, he goes to the doctor next door. This fellow falls from the window, he goes to the next door.
Yeah.
He gets a gallbladder surgery done in the neighboring nursing home. So the doctor also needs to know, and he needs to tell the doctor.
Yeah.
For everything, he will not have time to reach to a tertiary care center.
So the sick day schedule is the most paramount importance.
Absolutely.
While managing these patients.
Absolutely.
Fair enough. Thank you very much, sir,
God bless
for your suggestions and guidance.
Thank you.